Mark is a very special person. He is a very talented surgical oncologist. He's also the liver transplant specialist here in Halifax. I guess we've learned a lot about pancreatic cancer over the last couple of years from Mark, and he's been very generous with his time for Craig's cause. And a lot of or actually most of the money that we raise in Craig's cause, which now exceeds $500,000 since 2006, goes to Mark and his team for research into the early detection of pancreatic cancer. So Mark, I'll hand it over to you.
Thank you, Michael. Is it okay if I sit, or do you want me to stand?
As you want.
Sit away.
I know most people here. Anyways, so let's get started. That's White Point, in case you're wondering. I always like that picture, and I use this picture at the beginning of many talks because you look out there, you don't see any. You see a horizon, you just don't see any land on the other side, and that's what we're looking for: place to land, and a place that we can go to where we can try and solve some of the issues around pancreatic cancer, and that's happening slowly. Let's see. Oops, sorry. So this is really, I wasn't entirely sure. I've talked here, I think, once or twice before. I wasn't entirely sure who would be here, so I've tried to make it sort of interesting without being too simple, and also without, having a different point of view, because I know sometimes people come to more than one of these sessions, and I don't think anybody's talked about the history of this, the development of the treatments for this surgery, so we're going to talk a little bit about that tonight. But how are we doing and where are we going? That's really what we're talking about. And you guys have seen some of these slides. I apologize, but anyways, I don't know if you know, this is called an Edsel. It's a car that was a piece of junk, really. I think they only made it for 2 years. It was a dud in so many ways. It was an enormous failure. That was produced for 2 years and then discontinued. And I show that picture because that's really what the treatment of pancreatic cancer has been up to date. Really is not hugely successful, unfortunately, for many reasons. This is just some of the people who've had pancreatic cancer, adenocarcinoma. Patrick Swayze, we all know about him. Randy Posh, who co-wrote the last lecture. Luciano Pavarotti, an opera singer, he died of pancreatic cancer. Steve Jobs had a neuroendocrine tumor that was treatable, but he chose not. He chose not to go the standard therapy and did some kind of alternative therapy, and it got out of control. He eventually then went on to have a liver transplant, which is rarely done for this kind of cancer, but it sometimes is, and he recurred very quickly and died of metastatic disease. Anyways, we have an overview here of pancreatic cancer. So the most common kind of pancreatic cancer is adenocarcinoma of the pancreas, which is a abnormal proliferation of the glands of the pancreas that then forms tumor. Cystadenocarcinoma is a variant of that. And that represents probably about 90 to 95% of all pancreatic cancers that will be diagnosed in Canada this year. The other 5 to 10% are neuroendocrine tumors, and they include gastrinomas, insulinomas, and carcinoids. Pseudopapillary epithelial neoplasms or SPEN tumors, also known as Hamoudi tumors, are very rare, less than 1%, occur in young women. And we've had a series of 3 or 4 young women who've had them. That's a very curable form of pancreatic cancer. As are neuroendocrine tumors, they can often be cured. Pancreatic lymphoma is another kind that's very rare, but generally treatable with just chemotherapy. You don't have to actually do surgery. And then pancreaticoblastoma is a form of pancreatic cancer that we see in children that's extremely rare as well. The distribution, this distribution is 2008 data, it really hasn't changed. You can see here that on the left there's new cases in males and females of the types of cancers. So the big three cancers are prostate in men, breast in women, and then lung and colorectal cancers. And if you look at the mortality of these cancers, then, which is on the right column, you see again the mortality there for the various forms of cancers, which is fairly significant, especially for lung cancer. But remember, this is the total numbers because these are much more common cancers. Pancreatic cancer is a rare cancer, but it's a very deadly cancer. And if you look at the incidence here in the Atlantic provinces, you can see that in 1900 and then in 2000, how the rates have changed. You can see, the numbers have changed, and you can see that generally it's a little bit more common in females than in males, but somewhere in the range of 2,000 per year back in 2009, and now up to about 2,300 per year as of last year. And that will continue to grow. And part of that is because we're detecting it earlier because of all the imaging that's being done now. So it's the 9th most common cause of cancer, all cancers in Canada, but it's the 4th most common cause of mortality. So it just comes right after the big three cancers of lung and colon or breast and prostate. So the treatment of pancreatic cancer, if you don't do anything, you'll die from it. And the people who live for more than 5 years, there's some reported cases of people that they're generally either the diagnosis is wrong or it's some variant that is very rare that's not particularly aggressive. But most people will die if they're not treated, and the survival after you've been diagnosed with pancreatic cancer is around 6 to 12 months. Most people will be dead within that period. If you have surgery, the morbidity from surgery is quite significant. The most common operation being the Whipple, and it's a huge operation. I'll talk about that a bit. The morbidity is very significant. The mortality, or the chance of dying from the surgery, is somewhere between 1% to 5%. We, at our institution, we quote 2%, which is lower than the average. If you have cancer, if you have pancreatic cancer, you have a Whipple or some kind of, or a distal pancreatectomy, your chance of being cured of that cancer is about 15%. Recent data that Dr. Molinari has with one of his graduate students showing that that's gone up to about 20% now in Nova Scotia, and that's in the past 9 years. So our rates of curing are slightly improved, not massively so, but certainly getting a little bit better. Most of the disease of the pancreas is contained in the head of the pancreas, which is next to the duodenum. And that's why people who have that will turn yellow because the bile duct gets blocked, or may have symptoms of filling up, not being able to eat because the duodenum, which is the tube that empties the stomach, gets blocked. There you also get it further along the pancreas. The pancreas is shaped kind of like a fish, and in the body and the tail is where you can also see cancers. Those cancers usually present later and often at the time of presentation are metastatic. Recurrence of disease, this is the Achilles heel of treatment of pancreatic cancer, is most of them will recur, right? I've said that cure rates are between 15 and 20% with surgery, so that means 80% of people will get the cancer back. Most get it back within 2 years. And it's pretty well evenly distributed between occurring back in the pancreas, in the area that you've removed. There, you think you've removed everything, but you have, and there's microscopic disease that you can't detect that in a couple of months will grow back, or they have metastasis to the liver that you don't see at the time of surgery, again, because they're what we call micrometastases. So if you look at the overall survival of pancreatic adenocarcinoma, as I said, it's relatively dismal. And this was a huge study done in Italy where looking at 1,000 patients, and their survival rates were about 15% out to 5 years. So at the CDHA, of 100 patients that we see, 60 will be clearly unresectable, which means they will not benefit from surgery. There's no hope for curing them. 40% will be treatable with surgery, although that will change at the time of the operation, in which up to 16 to 20% of those will not be treatable at the time of surgery, either because the tumor's grown too much or there's metastasis that we don't see on imaging beforehand that are present when we do a laparotomy. Those patients will go on to have palliation, and then there's about 25% of people who will have surgery, and of those 25%, 4 to 5 will be cured, which works out to be between 15 and 20% of all comers up front. So the treatment is the Whipple procedure. The pancreatic duodenectomy is the most common one. We do that about 80% of the time, and 15-20% of the time we do a distal pancreatectomy where it's located in the tail of the body. And those now almost always are done laparoscopically. The Whipple is not done laparoscopically. That's done traditionally as an open surgery. So let's talk about this procedure. This is an Italian, not related to Dr. Molinari that I'm aware of. He went on to have a career in orthopedic surgery, believe it or not. But he has the distinction of performing the first Whipple procedure on a patient who died a day later. It was a morbid procedure then, and it still is. The person who really popularized, or not popularized, but who made surgery on the pancreas possible was Walter Krausch, who was a German surgeon who had a series of about 20 patients with cancer, mostly cancer that's periampullary, not truly pancreatic, but in that area that would require a Whipple. They went on to be treated, and we'll talk about his results too. Then the person who the Whipple is named after is a surgeon, Alan Oldfather Whipple, who perfected the operation. This operation at one time was 3 stages. The patients would be operated on 3 times, and it became 2 times, and it became 1 time, which is how we do it now. And that there's actually a Canadian link in the history of pancreatic cancer, because this person, Roscoe Reed Graham, who was a Toronto surgeon, well known for his publications on gastric surgery, and was a surgical oncologist back in the 40s in Toronto. When Edsel Ford became sick with pancreatic cancer, he was sent to Dr. Graham, who operated on him. And he had a number of complications from the surgery. He eventually died from his surgery as a young man at the age of 45. So when we decide to do an operation, the most common form of image that we do is an ultrasound followed by a CT scan. Some people get MRIs, which are sometimes helpful. But generally, a pancreatic protocol CT is the way we would work almost all patients up for. And this imaging, I don't know if you can see it or not, but I'll just show you some structures here. So this here is the pancreas. That's your spleen. That's your liver, parts of your liver. These are just cuts as you're moving up through the body. And the tumor here, it's hard to see, but the tumor here is right there. This structure here is called the portal vein. And there's the superior mesenteric artery right there. And we have to dissect all this tissue off of that. If it's too stuck, then we remove the portal vein as well. That's rare that we have to do that. These are just some more cuts, again, of the imaging. Again, you see a better view of the vessels. The superior mesenteric artery that's the artery that feeds all of your bowel, small bowel, and your colon, your duodenum, your pancreas. You cannot survive without that vessel. If you damage it, you'll die from a bowel that doesn't work any longer. And one more shot. So here, this is a blow up again of the same imaging. You can see that the pancreas now, again, you can see the pancreas, how it comes way out to the spleen here, and then there's the tumor. There's the bile duct with tumor around it. So let me just go back here. So there, as they're saying, many patients who have pancreatic cancer will present because they're jaundiced, they're yellow. This here's the bile duct that's become dilated because the tumor's pushing on it, not letting bile get into the duodenum. The duodenum is wrapping around here, and there's the gallbladder. So that makes you go yellow. That's how many people will present, and that's why people with lesions in the head of the pancreas will often present a little bit earlier than the people who have lesions in the tail. So let's just talk about something else, this is actually a Canadian study looking at the history, again, Whipples and what happens when people who do them shouldn't be doing them. So this is a study that was done in Ontario, looking at centers where there was less than 10 Whipples done versus 10 to 20 versus greater than 20. And you can see that they're looking at here's more as operative mortality. And so in here, where it's a center where somebody, it may not even be one surgeon who's doing 10, it may be 2 or 3 surgeons who are doing 1 or 2 a year. With that, their operative mortality is greater than 10%. And this was, again, this is suggesting that in that era, a lot of people were doing these surgeries, and that the mortality is very high. If you go to the next area, which is here, which is 2002 to 2004, so later on, where there were some restrictions on who was going to be doing these operations, the results got better. And again, if you go to centers where there's more, and this is us here, this is a center like, this is the University Health Network, and we're similar. Dr. Molinari and I are the only people who do Whipple procedures now in Nova Scotia and PEI, and really most of New Brunswick, and we do between us about 40 to 45 Whipples a year. So we consider to be having a very large volume practice. So your mortality in these large volume practices should be somewhere between 2 to 4%, and that's what this shows. So the surgery should be done in centers that are just going to do the surgery, where it's not just about the surgeon, it's also about the center that's set up. So the oncologists that are involved, the radiologists, the nursing, the ICU, all of that plays a role in how patients are going to do after this very morbid operation. I told you I'd talk about those surgeons and their results. So the little Italian guy who went on to have a career actually in orthopedic surgery, his mortality for his one Whipple was 100%. Dr. Crouch, there's just anecdotal reports as to how he did, but he did more than 20, so people were obviously surviving to some degree. Dr. Whipple, who did, remember, he was operating back in the 30s and 40s, he had a very high morbidity. So this is major morbidity. Now, I'm not talking about urinary tract infection or pneumonia. We're talking about major leaks or bowel leaks. And his mortality was 30%. Nowadays, we would expect a major morbidity to be around 20 to 40%, and a mortality, as I said, between 1 and 4%. So what happens if you can't have surgery for this disease? So non-surgical treatment is really chemotherapy plus or minus radiation, and that can be used sometimes in people who have disease that looks resectable. Some centers, everybody gets preoperative chemotherapy and radiation. We don't do that here. Locally advanced disease, so disease that would be, when you look at the imaging saying, I can't get that tumor out, I'm not going to be able to have what's called a negative margin, so I'm not going to be able to do the surgery and not end up leaving a small amount of tumor behind. So in that kind of situation, you can give them chemotherapy and radiation ahead of time and try and shrink that tumor. We've done 6 patients like that so far, and we've had 2 that have gotten to the point where they could have surgery, one of whom is tumor-free. So, and then for metastatic disease, and in this case, people who have metastatic disease, the role of chemotherapy is really palliation to make them feel better. And so just quickly, some of the trials. This is the first big trial looking at the effects of 5-FU, which is an old form of chemotherapy that's used in colon cancer. We used it also, and looking at people who got it, and the people who got it had a 43% increase in survival. So that was better than what we were expecting before. I went on then to do another trial looking at adding gemcitabine, which is another chemotherapeutic regime, and seeing again a slight improvement in patients who've gotten chemotherapy versus those who have not. You can see that the dark, thicker curve here is, again, the chemo survival over time versus no chemotherapy at all. So the ones who got chemotherapy, more of them survived than those who did not. So now looked at, or not us, but other groups people have looked at adding on biological agents. So bevacizumab is Avastin. I'm sure you guys have heard about that in the news. Again, a very expensive drug, looking at survival of about 29% at 12 months. So didn't add really a whole lot more, but certainly it's some percentage of the United States, this is what everybody would be getting. And then this is a Canadian trial looking at another medication, another biological agent, which is an antibody or lotinib. And this study had a poor result, really showing that there was about a 17% difference in those who got it versus those who did not. So really very poor results. Now, interestingly, out of France, is encouraging and depressing at the same time. Dr. Thierry, who was the chief author on this, came and talked last year, and they've been using a combination that we've used in colorectal cancer called FOLFIRINOX, and they've looked at that in metastatic disease. So people who don't have surgery but who have pancreatic cancer and it's not being resected, who go on to have this medication, looking at their overall survival. In fact, their overall survival is significantly better. Again, though, this is in the metastatic group, so all of them will die of their disease eventually, but they do live longer. And now I don't have the data here, but a recent adjunct study shows that they do better in terms of their quality of life as well on this chemotherapeutic regime. And again, their disease-free survival, again, it shows that they are disease-free for longer, although eventually it does come back to kill them again, because this is metastatic disease. The question is, how is this going to work in patients who don't have metastatic disease? So there's really no trials right now to suggest that you should use it up front for people who have had resections, but that will happen. So what's happening here at the CDHA is there's a pancreatic cancer database that we're part of, and there's a group in Quebec that started up that we're going to be working with. There's Dr. Molinari, who started a large cancer database that's been going on now for 9 years, looking at all the outcomes. And we're really spending a lot of time trying to educate health professionals and the public as to what is available for people who have pancreatic cancer. It's interesting, in a study, again, that Dr. Molinari published, and in other studies that have been done, 40% of family doctors believe that if you have pancreatic cancer, that it's hopeless. 40%. So that's almost half of all family doctors. So that's something that we have to try and work against. Because the reality is that survival rates are poor, and they were very poor for a long time, especially here. They have gotten better very slowly. Let's just see here. So is treatment of pancreatic cancer an enormous failure from 1909 through 2009? I don't know. It's very slowly getting better. The last slide I showed you from the group in France, Dr. Thierry, that's just, published in 2011, so that's really only a year and a half old. So things are getting better slowly. Dr. Molinari's most recent data also shows that our survival rates are going up to around 20% now rather than 15%, again, suggesting that we may be making some progress. And that's for adenocarcinoma. For the other kinds of pancreatic cancer, we're doing even better. Are there any questions? So the question is about jaundice. So jaundice, 70% of people with pancreatic cancer present with jaundice. There's other reasons to become jaundiced. Liver failure, some kind of hemolytic problem can do it. But generally speaking, people who have pancreatic cancer or jaundice also have weight loss. Anybody who has weight loss and jaundice needs an ultrasound. That's the first thing you should do, and blood work. Yeah, sure. So the question about the symptoms, as I say, 70% will get jaundiced, weight loss. About 10% will have significant back pain. That's not lower back pain, but kind of mid-thoracic back pain. That's a very worrisome feature. fatigue. Sometimes people can be anemic, even that's unusual. Those would be the more common things, but you say fairly general things. The other thing is that usually, most of the time in people who are over 50, so that was in a way the problem with your daughter because she was young and healthy. You do not ever, it'd be uncommon to think of that in a young person, but it does happen, particularly in young women with the SPEN tumors. But a lot of the cancers that we are seeing now are found incidentally now because people have had a CT scan for some other reason. Very common to have that. Other symptoms are nausea and sometimes vomiting, or even just you didn't have reflux before, which is acid, heartburn, you may be getting that. New onset of diabetes, somebody who's over 50 and all of a sudden they become very significant diabetic with no risk factors for developing diabetes is something you should worry about too. I've seen that a number of times. Or people who are non-insulin dependent diabetics who become insulin dependent all of a sudden, even though they're doing all the right things. Again, those are worrisome features. Yeah, so the first thing is that anybody who has pancreatic cancer, I don't care if it's treatable or not, or surgically treatable or not, I like to see them all. Doesn't matter. And I tell that to all the family doctors. And then I have a conversation. Usually it's the only time I'll see them. We review their imaging and talk about whether or not we think the tumor can be removed or not. If it's not removed, which is most of the cases, unfortunately, there's still many options for treatment, not cure. So you have to think if a cure, that's great. That's the ideal situation, but most of the time there won't be cure, it'll be treatment. And treatment involves many things. So palliation is part of it, which is pain relief, maintenance of your health with good diet, being able to eat, maintaining your level of energy. There's chemotherapy as well. So chemotherapy, as I said, some of the regimes, there's two that we use at this institution, can help you maintain your weight better, give you a little bit more energy, give you a better quality of life. And that includes the placebo effect of chemotherapy too. You believe something's going to help you, and often it does. There are numbers of treatments for pain, because pain can become a real issue with pancreatic cancer, and it can be absolutely debilitating. So we've had some success, certainly with Dr. Beaupre and Dr. Berry with injections of the celiac plexus, where you inject the nerves around the pancreas to kill them, so you don't have that sensation of pain anymore. It doesn't affect your ability to move in any way. People who are jaundiced can have what's called an ERCP, where we put a light down your stomach, put a stent up your bile duct, and that we can give you a stent that's a permanent stent, so it doesn't have to be changed, doesn't get blocked. That really makes you feel. It's amazing how many patients I see after they've had an ERCP done, they come back and say, "Oh, I feel so much better." When you're very jaundiced and you're itching, you're not hungry, you feel tired, and then all of a sudden that's cleared in 2 or 3 weeks, you feel much, much better. And yes, you're not going to be cured, but again, you've had some help with that. So palliation is, covers all kinds of things, not just pain control, but symptom control as well. The other thing too is that I always tell patients is the importance of family, because in my experience, people who don't have anybody don't live. They all die very quickly. Those who have family members, and they always do better, even if they have worse disease. And I think, it's very important that family members come to appointments with their loved ones, because it's informative, because sometimes the patient doesn't hear everything, or I think I've told them something and maybe I didn't. So it's good, and there's nothing wrong with lots of questions. That's what you're there for. I'm going to talk to a lot more patients than I'm going to cut open, right? So I like to spend time talking to them. Yeah, so there's lots of treatment options, not many cure options, but there's lots of treatment options, and it's wrong to say that there aren't. The other thing is, too, is you have to make sure you're treating the right tumor. It does happen where you're being told one thing that's wrong. And usually my spider sense, for want of a better word, tingles. And I see something that doesn't make sense. And when you do more investigation, it turns out it's not pancreatic cancer. Somebody's told that in emergency you have pancreatic cancer. That's why I insist on seeing everybody, because I've caught 3 people who were diagnosed who don't have cancer. And they're okay, and so that's great.
Mark, should family members be concerned about the disease being hereditary?
It is, but it's extremely rare. People who have family history of breast cancer with BRCA mutations, they can get it for sure, and they should be seen by, well, usually they'd be seen by a surgical oncologist regarding their breast disease, and they can make a decision as to whether or not they should be seen by one of the hepatobiliary surgeons regarding that. There are families of pancreatic cancer that do exist in Quebec and in Toronto, and they're following. We're looking for families here. I thought we had found one last year, but the family members didn't want to be screened, so I think foolishly, but anyways. The big issue with risk factors for pancreatic cancer is, smoking is one of the risk factors, but it's really not a, I'm not saying go out and smoke, but I'm saying it's not a huge risk factor for pancreatic cancer. Pancreatitis is, though. We see a lot of pancreatitis here, and familial pancreatitis certainly is. And you don't know. You don't know with people who have pancreatitis, who have recurrent attacks, whether or not that truly is a cancer or whether it's just pancreatitis. And if it is pancreatitis, if it's going on for years and years, it's an inflammatory process, it can become malignant. So those are the groups that we would worry about. So yeah, so it's always worth it, again, for family members who are concerned, to go and talk to about it, for sure. And people who are concerned, so there's no evidence what I'm going to tell you right now in the literature, but people who are concerned, I just get them to have an ultrasound. It gives them peace of mind, and it's a cheap test that's relatively sensitive. I don't like to order tests for non-agreed, but anyway, sometimes I think it can be helpful. So.
Your opinion on second opinions?
I think they're fine. I have anybody, if you go to see a surgeon who's offended by having a second opinion, they're a moron, in my opinion. I don't care. I offer people a second opinion because you meet people and say, well, that's great, have a second opinion. If you want a second opinion, often Dr. Molinari, we actually run our clinic the same day. So we're always happy to see somebody if they want a second opinion. Or if they want to see a second opinion somewhere else, there's somebody in New Brunswick now who does Whipples, who's very well trained. I would send them to him. Or I've sent people to Toronto and to Montreal who want an opinion. That's fine. Why not? If they want to spend the money, that's fine. I think it's very reasonable. There's not very much, and generally it would be very rare to find a disagreement. Occasionally there are. Occasionally, there's differences in opinion. For example, the age at which you'll operate on people for pancreatic cancer. So the literature is not really definitive on that. And certainly, I would be very hesitant to operate on anybody more than 75, only because the morbidity of the surgery is so high and the chance of curing is so low. Most 75-year-olds in maritime Canada are not, have other comorbidities. But I have done a Whipple on an 80-year-old, but not for pancreatic cancer, but for another kind of cancer, cholangiocarcinoma, which is sometimes mistaken. But they have a different biology. People who have neuroendocrine tumors, I would certainly do in an older person for sure. Yeah, but adenocarcinoma, I'm not sure. You'd have to be perfect. Because there's people in this room who can tell you that you can be very sick from a Whipple if things don't go right, and that does happen, unfortunately. So people who get it back in 2 years' time, then generally, either they'll often have symptoms with it, and then they would get palliative chemotherapy. So, but not everybody does that. About 80% of people it will happen, though, unfortunately. Yeah. There's no absolute cutoff for age. There is, though. You have to be, more cautious, obviously, as people get older. The problem, if it was like it was like breast cancer. So, breast cancer is a very straightforward operation, and you can have complications from it, but it generally is not. So you would do that in people. But if the surgery itself is such that the surgery alone can kill you, you have to be careful about how you apply it. Often, the other thing that we find here, again, Dr. Molinari, his data shows us, is that we get people presenting later. Like my colleagues elsewhere in the United States and in Canada will see people that have, who have shown up after, 2 or 3 weeks. I've seen people after 2.5 months that they haven't been waiting 2.5 months to see me, but that's when they first had their symptoms, or things were detected. Things were detected 4 months ago, and nothing was done. And then by the time you see them and you go back to the trial, you realize, it's now too late, which is very sad. That happens here, unfortunately. It's getting better, but as I say, 40% of doctors, and I say family physicians includes emergency room doctors, believe that there's nothing you can do. What's it like? Well, you have an expert on recovery sitting in this room, and it's not me. But it can be very straightforward. I've had people get out in a week. Most people get out in about 3 weeks' time. About 20% of them need a drain placed at some point because they have a leak, where you hook the pancreas up to the bowel. But I've had people who've been in for 3 months. That is not common, but it happens. It happens about once a year, I would say, with my patients. So about 5% of the time you have a complication that's enough that they end up being in for a long time, sometimes requiring a number of surgeries, a number of procedures.
So how hard is it to get eating again and moving again?
So again, people who recover, within the 3-week period, their stomach will not be normal for up to 3 months. It takes that long for it to start to work properly. And sometimes, occasionally, they'll have to have more surgery later on, because people can have, the way we hook the stomach up, sometimes it can cause problems, different kinds of problems. Sometimes they'll need to have more surgery. That's not common, though. That's pretty rare. In terms of activity and moving around, I like to see people up, if not the next day after surgery, then the day after that. They often will have an epidural so they can get up and get around. And what causes significant postoperative problems with these patients are something called pulmonary emboli, where they get blood clots in their legs that spread to their lungs. And that's one of the big killers in pancreatic cancer. And we know people with pancreatic cancer are much more susceptible to that, so it's very important that they get up and move around. But in terms of eating, as I say, once their bowel function starts to work, then they can eat pretty well whatever they want. Yeah. They will tend to eat more frequently and a little bit less when they do eat, but eventually the stomach should get back to normal. The only thing that we recommend here is things that are proven in good clinical trials. There's all kinds of things you can do still. The evidence to use various biological agents like bevacizumab and things like this is not strong. It makes probably some benefit. The question is how much of a benefit versus how much it costs. I know you're not supposed to say that when people have cancer, but that's the reality in this kind of system that we work in. And many of these agents are not without their side effects, right? They can have significant side effects, and therefore you have to be cautious about using them, especially when the benefit is marginal at best. And yeah, there's all kinds of things that can be done, and certainly some centers are very aggressive about things, but in select patients who we think will survive more aggressive forms of therapy, we would advocate, for example, radiation and chemotherapy ahead of time if they need it. If they don't need it, then they should go ahead for surgery. That's still your best bet. Yeah. Now, another tumor I didn't talk about, but it's becoming much more common, is something called IPMN, which is a tumor we're seeing a lot more now. It was really unrecognized until about 15 years ago. And that's also a form of pancreatic cancer. It's very curable, and we're seeing a lot of it, and it's often being found incidentally now because of imaging studies. They say that's partly probably why our rates of cure are better, because we're seeing it earlier. We're seeing these sorts of tumors, and because people are having a CT scan 15 years ago was something that nobody had, or rarely. Now it seems like everybody's getting them. It's very, very, very common. I'm not advocating that as a screening tool, though. I don't think there's any evidence to suggest that, but yeah. That's pancreatic cancer, the reason why it kills people is because it presents late. That's the reality, unfortunately. It's right at this, the pancreas is the most central part of your body, really. Lies right between your heart and your belly button, and therefore it's the very core of what you are. So when it goes wrong, you don't see it till too late sometimes, a lot of the time.
Is there any promise showing in any of the alternative medicines that are being done in conjunction with traditional treatment?
That's been supported by good quality studies, no. People want to try things, and I think that's reasonable. I'm not opposed to people trying other things. I think I am opposed to people spending a lot of money on things for which there's no proven, benefit to doing. But a lot of people are now taking alternative therapies. Those sometimes can cause problems with your liver. It really depends upon which ones. But and as long as they don't interact with the chemotherapy, then I'm not against them. But I'm not really authority on that, unfortunately. So, but the problem with those therapies is the people who advocate most strongly for them, there's no evidence. They just say, oh yeah, this has been shown to work, it's okay, great. It may work, I don't know, but there's really no good evidence for it, so it doesn't hurt you, go ahead, I would say.
Is there dietary risk factors for this, you think?
For pancreatic cancer?
Yeah.
Not really. Nothing that's been established clearly as being a true risk factor. No, not really. As I say, if you look, the studies that's showing risk factors, there's really very little.
Like high meat consumption versus high risk
Yeah.
low meat.
So that's one of these things. The relative risk of that is like 0.1, which is meaningless, really. It's not being well proven. Even smoking, as I said before, smoking is a risk factor probably for all kinds of every cancer, I guess, realistically, but pretty minimal. The people who are getting it, the other problem is, we like to think, is there going to some way we can detect it earlier, but it's not like breast cancer, right? Most common female cancer. It's only 20% of them are really related to genetics, and the other risk factors that we see somehow can be, correlated to that, but most of them are still sporadic, and that's true for pancreatic cancer, unfortunately. But the biggest problem is, it's just hard to find. You don't see them early. Some kinds of neuroendocrine tumors, though, you can see running in families, and those people we keep a very close eye on. But again, most of them are not. Most of them are sporadic tumors.
How long do you think, Mark, it's present before it's presenting? Do you have any indication?
Well, I've seen ones grow within the space of 8 months rapidly. They were thought to be nothing and turned out to be a cancer. But then there's other ones that, we don't know how long. It's logarithmic the way cancers grow. So we know for colon cancers between 5 and 7 years, from being nothing to becoming an adenoma and then a polyp and then cancer. We don't know that for sure for pancreatic cancer, but it's probably somewhere in the same kind of range where you have, particularly people who have pancreatitis, where they have chronic inflammation that then develops into a cancer. But it probably a couple of years at least, 2 to 3 years. And we know with some of the cystic lesions, which are just little fluid-filled sacs, those can become cancerous when they get above a certain size. So we just follow those very closely, like every 6 months or every year or so. So your sister has pancreatic cancer.
Yes.
If you had a brother who had it, I would say absolutely, you should have an ultrasound tomorrow.
If I had
A brother or another sister or another member in your family.
so 2 siblings.
The 2 siblings or one of your parents and your sister, then for sure. If it's just an isolated case, then there's, as I say, no evidence. Unless, for example, you have a BRCA mutation for breast cancer in your family, or most people, but again, most breast cancers don't have that. And I don't know the type of tumor that your sister had. If it's an adenocarcinoma, I'm assuming it was. But if it's a neuroendocrine tumor, then sometimes those sometimes can run in families. Sometimes. But most of the time, again, they don't. It's bad luck. That's what people ask me, why did I get this? And the reality is it's just bad luck. That's unfortunately what it is.
Is there anything at all promising in a acute screening test?
There's some kid in the States who's...
Yeah,
I have yet to see... I'd like to know. I'd really like to see the data on that. I mean, there's all this hype about it. Who knows? It's possible. Maybe that will work. I don't really know. The idea behind it makes a lot of sense, right? And he's obviously a bright young guy. So we'll see. And they're doing a trial to see. Unfortunately, what's happened in the treatment of cancer, there's always great ideas that just do not translate, right, for whatever reason, because it's a more complex process than we appreciate. But yeah, who knows? It's there's things that people have thought were crazy, like treating bladder cancer with extracts from tuberculosis, treating bladder cancer. That people thought that was insane, but it works. It works very well. In fact, and now it's a standard therapy in some places. They do it. And the guy who did that was ostracized for it. Or, erectile dysfunction, treating that with drugs and things like that. People thought it was crazy, but it turned out to be true. So there are all kinds of things in medicine that seem crazy, and people, talk about that it's crazy, but it turns out that they're right, so who knows? Yeah, so and that kid isn't crazy. He's not crazy. So who knows? I don't know. Maybe it will work. It'd be great if it did.
Well, Mark, thank you so much.
Yeah.
On behalf of Craig's Cause for coming out. I think we all feel really fortunate to have both you and Dr. Molinary
Thank you.
as resources for us, as fundraisers for us, as researchers. You're doing so much for the cause of moving this disease forward and looking for treatments, and we really value your dedication.
Thank you.